Welcome to the deep dive. You've handed us a dense and incredibly important stack of sources today,
Yeah.
all focused on understanding multiple sclerosis, or MS.
It's a deep dive that's definitely overdue. We have a really robust collection here. Everything from the fundamental biology to the cutting edge of treatment research.
So our mission today is to synthesize all this to build a clear foundational understanding for you.
Exactly. Think of this as the shortcut to being truly well-informed about what MS is and what it isn't.
And we're talking about an illness with a massive scope. The sources are clear. MS is an immune-mediated central nervous system disorder.
An immune-mediated CNS disorder.
Yeah.
And it's not rare. Nearly 1 million individuals in the United States alone have been diagnosed.
Wow. That number alone tells you why this matters.
And what stands out right away from the source is what makes it so challenging is just the sheer variability.
How it presents itself?
Right. The symptoms, the manifestations, they differ wildly depending on which part of the central nervous system is being affected at that moment.
And it's tricky because the disease can almost disguise itself, especially early on.
Precisely. We see initial symptoms that frequently go into remission, sometimes for a long time.
Yeah.
So you might have this cluster of really concerning symptoms that just disappears.
Which would make getting a diagnosis incredibly difficult.
Incredibly difficult. Diagnosis relies on evidence of damage in different places at different times. So if the symptoms vanish, pinning it down early becomes a real challenge.
Okay, so let's unpack the core mechanism here. If it's an immune-mediated disorder, what is the immune system actually targeting?
Let's use that classic analogy of the body's electrical system. Your central nervous system, so the brain and spinal cord, it's made of millions of tiny wires, axons.
Axons, right, transmitting all the signals.
And to make sure those signals travel quickly and efficiently, each axon is wrapped in a protective fatty layer. That's the myelin sheath.
So the myelin is like the plastic coating around an electrical wire. You need it for the signal to conduct properly.
You absolutely do. In MS, for reasons we don't fully understand, the body's own immune cells get through the protector field around the brain.
The blood-brain barrier.
They cross the blood-brain barrier.
Yeah.
And once they're inside, they launch an attack on that insulating material, on the myelin. That process is called demyelination.
And that's when the signal slows down or short circuits, which would explain all those confusing intermittent symptoms.
It does at first. When the myelin gets destroyed, it causes inflammation. And that inflammation leaves behind scars. We call them lesions or plaques.
Okay.
Now, here's where the real long-term danger comes in. If the attack was only about stripping the insulation, the body could potentially repair some of it. The cells that make myelin, they can sometimes regenerate.
But the sources are very clear that the damage can become irreversible. So how does that happen?
Because the attack doesn't always stop at the myelin. When the inflammation is severe and it happens over and over, it starts to damage the wire itself.
The axon.
The axon. And damage to the axon is permanent. The sources say repeated attacks lead to more plaques, and once the axon is damaged, that function is lost. For good.
So the aha moment isn't just about a disrupted signal. It's about a process that moves from a temporary disruption to, permanent destruction of the nerve itself.
Exactly. And that makes controlling those attacks the absolute priority.
Which brings us to the patterns of the disease, how it unfolds over time.
Right, from the what to the how. Our sources categorize MS into 4 distinct types, and understanding these is really key to the whole management strategy.
Okay, let's go through them.
The good news, if you can call it that, is that the vast majority of people start with the most common form, relapsing remitting MSGATS or MSS.
Relapsing, remitting.
Think of it like a chart. You have these periods where the disease flares up, that's a relapse and it can last for days or months, and then the chart recovers. That's remission.
And during remission, the symptoms can go away completely?
Partially or completely, yes. And these cycles of flare-ups and recovery can go on for weeks, months, or even years.
That seems like the most manageable pattern, at least initially. But what happens when that recovery phase stops?
Then you're looking at the progressive forms. First, there's primary progressive MS, or PPMS.
Primary progressive.
This is continuous. From day one, the condition just slowly but steadily worsens. There aren't any of those clear remissions. It's just a slow, continuous decline.
So a steady downward trajectory right from the start.
Right. Then you have the next type, secondary progressive MS, SPMS.
Secondary. Go.
This usually develops in people who started with the relapsing remitting form. The sources say about half of untreated patients will transition to SPMS.
So they had the up and down cycles for years, and
And
then,
then the disease just switches modes. It enters a progressive phase, a lot like PPMS, where the recovery periods just fade away or stop altogether.
that transition sounds like a really critical point for prognosis. And what about the last type, the rare one?
That's progressive relapsing MS, or PRMS. It's rare, but it combines elements of the others. You have that steady, progressive worsening from the start, like PPMS, but you also get acute relapses on top of it.
Oh, wow.
And the key thing is, in the time between those relapses, the condition is still getting worse.
Yeah.
It never really enters remission.
That distinction, whether the downtime is recovery or just continued progression, that seems vital. So let's pivot to the risk profile. The sources say the exact cause is unknown, but we have some strong links, right?
We do. It seems to be this complex interaction between environmental, infectious, and genetic factors. It's not a single gene disorder, but we can paint a pretty clear picture of who is most at risk.
And what's the biggest factor the sources point to?
Demographics are key. MS primarily affects people of Northern European ancestry.
Interesting.
The age of onset is typically between 20 and 40, a really critical time of life. And crucially, it's significantly more common in women than in men.
I was also struck by the lifestyle factors, especially smoking.
Yeah, smoking is a clear and consistent risk factor. It increases your chances of developing MS, and if you already have it, continuing to smoke is linked to a much faster, more severe progression of the disease.
And then there are other environmental things like geography, sunlight exposure.
Right, which links to vitamin D levels.
Yeah.
And the genetic part is nuanced. It's not strictly hereditary, but having a first-degree relative, a parent or a sibling with MS, definitely elevates your risk.
So with all these different factors, it makes sense that the disease looks so different in every single person.
That's the perfect way to put it. And that brings us to the sheer variability of the clinical symptoms.
Right, the idea that no two patients have the same set of symptoms, and for someone living with it, trying to figure out if a bad day is a true attack or something else must be so difficult.
That distinction is vital. Our sources give us three terms. A true exacerbation is defined as new or worsening symptoms that last for at least 24 hours. That's a genuine relapse.
Okay, at least 24 hours. What if it's shorter?
If the symptoms last less than that, they're called paroxysmal attacks. These could be, sudden brief spasms or a short bout of numbness.
And then there's a third type, which isn't a real attack at all.
Correct. That's a pseudo-exacerbation. This is a temporary flare-up of symptoms, but it's triggered by something else.
Yeah.
An infection, a fever, even just getting overheated.
So it's not the disease progressing.
Exactly. Once you remove the trigger, the symptoms fade. But true relapses themselves can be triggered by things like stress, fatigue, or infection. So it's complicated.
Looking at the range of symptoms, it's just staggering. They can touch almost every system in the body.
They can. The central symptoms are often the most profound. Pervasive fatigue, clinical depression, and major cognitive issues. Memory, processing speed.
And then the visual problems are very common too, right?
Very. Optic neuritis, which causes pain and vision loss, or double vision diplopia.
And then you have the more, I guess, classic physical issues that people think of first.
The muscular symptoms, yes. Weakness, cramping, spasms, a severe lack of coordination. You combine that with sensory issues like paresthesia.
What is paresthesia?
That's the tingling, burning, or pins and needles sensation. When you put all that together, the impact on daily life is just immense. Not to mention things like bladder and bowel dysfunction, chronic pain, and sexual dysfunction.
And what's fascinating is that our sources even point out variability across different demographic groups.
They do. For example, African-American patients are often older at diagnoses. They tend to have more symptoms, and unfortunately, often a more progressive disease course.
But then for other groups like Hispanic patients, the data is different.
It is. They're often younger at diagnosis and seem to report fewer issues with mobility or bladder problems. It really underlines the need for personalized care.
And we have to mention older adults. The sources point to a really specific risk there.
Yes, as people with MS age, their symptoms can become more severe. But there's a specific concern with dysphagia, which is difficulty swallowing. The risk increases significantly for people over 60.
And the number was, what, 27%?
27% of people with MS in that age bracket develop it, which has a huge impact on nutrition and safety.
That's a powerful point. So let's shift to the practical side. Management and treatment. How is this actually diagnosed?
The diagnosis is a process of, really, exclusion and aggregation. There's no single test for MS.
No silver bullet.
No. Doctors combine a detailed medical history and a physical exam with a whole battery of tests. An MRI to see the lesions, a lumbar puncture or spinal tap to analyze the fluid.
And things like evoke potential tests and blood tests.
Exactly. You have potential tests measure the electrical signals, and blood tests help rule out other conditions that might look like MS.
So once that diagnosis is confirmed, what's the core strategy?
The primary approach is pharmacologic therapy. The goals are twofold. First, stop or at least reduce the frequency of the immune attacks. And second, manage the symptoms from the damage that's already been done.
And that list of disease-modifying therapies is long. Biologics, interferons, monoclonal antibodies.
It is. Instead of memorizing the names, just think about their function. Most are designed to modulate or suppress the immune system to keep those cells from crossing the blood-brain barrier.
And what about for an acute, severe relapse?
For that, they often use high-dose corticosteroids for a short time because they're incredibly powerful at reducing inflammation.
And our sources really stress the importance of the nurse's role in all of this. Patient teaching, monitoring for side effects.
It is absolutely essential. The side effects can be serious. Corticosteroids, for instance, can lead to glucose intolerance or osteoporosis over time. Patients need to be really well educated.
And beyond the pharmacy, what about the non-drug therapies? Regaining function.
This is where the multidisciplinary team really shines. It's arguably just as important as the medication. We're talking about physical, occupational, speech-language, cognitive, and even vocational therapies.
So it's less about a cure and more about maximizing the potential of what function is left.
It's about adaptation. It's about maintaining quality of life. And alongside that, you have the essential lifestyle factors. Plenty of rest, avoiding excessive heat, a balanced diet, staying hydrated, all critical.
What about complementary approaches? I see things like acupuncture, aromatherapy.
They're popular, and many patients report they feel better using them. The risk is typically low, but the sources caution that they often lack strong clinical evidence.
And a warning about herbal supplements.
A huge warning. They can have negative, sometimes dangerous interactions with the prescribed medications. So that needs extreme caution.
And surgery. It's not common, but it's mentioned for very specific symptoms.
Right. It's not a treatment for the disease itself. But for severe intractable pain, a procedure called a rhizotomy might be used to cut the nerve fibers sending the pain signal. Or a pump can be implanted to deliver muscle relaxants directly to the spinal fluid.
Okay, this is where it gets really compelling. The frontier. Stem cell therapy. This feels like a complete paradigm shift.
It's the ultimate goal. The hope is to reset the faulty immune system entirely. And we have some really powerful data from a 2020 NIH study on something called non-myeloablative autologous hematopoietic stem cell transplantation.
Okay, that is a mouthful. Break that down for us.
Of course. Autologous means the cells come from the patient's own body. Hematopoietic means they are blood-forming stem cells.
Okay.
So they harvest the patient's healthy stem cells. Then they use chemotherapy to wipe out the malfunctioning immune system. Then they reinfuse the healthy stem cells to regrow a brand new immune system.
One that hopefully doesn't have the defect that causes MS.
That's the idea. And the study found that this approach, HSCT, showed real promise in prolonging the time to disease progression. It could potentially halt relapsing MS entirely.
That's incredible. It's like turning the whole factory off and on again. But what about repairing the damage that's already there?
That is the second frontier. And the research here is intensely focused on something called oligodendrocyte precursor cells, or OPCs.
Those are the cells that make the myelin sheath in the first place.
Precisely. These OPCs can travel to the site of damage and produce new myelin to rewrap the nerves. If researchers can figure out how to harness or stimulate these cells, it suggests a path toward not just stopping the attack, but actually repairing the damage.
That would change everything.
Everything.
Okay, so wrapping up this deep dive, we've established MS is this highly variable, immune-mediated attack on the myelin sheath.
Which leads to irreversible axon damage over time.
It's categorized by 4 distinct patterns, most commonly relapsing-remitting, and its impact is systemic.
And managing it requires this huge multidisciplinary collaboration. Doctors, nurses, therapists, specialists, all working together is just non-negotiable for improving quality of life.
And so here is a final provocative thought for you to take away from all this. Our sources confirm these strong links to environmental and genetic factors, But the fundamental cause, what specifically allows the immune system to cross that blood-brain barrier in the first place, is still unknown.
Still a mystery.
So given this incredible research into stem cells to reset the immune system and OPCs to regenerate myelin, what essential shift in research needs to happen next to pinpoint the core vulnerability that lets those immune cells through that barrier to begin with?
That is the million-dollar question.
Yeah.
Finding that initial trigger. Thank you for sharing your sources and letting us dive into this.
Always a pleasure. We look forward to seeing what sources you send our way next time on The Deep Dive.